Hello everyone, welcome to this video on treatment of chronic stable angina. So if you see previous videos, what all we covered symptoms, we covered pathogenesis, we covered treadmill test, which was very important. In this we will cover treatment of chronic stable angina. So first thing, remember, not all ischemic diseases require immediate percutaneous coronary intervention or CABG. So chronic stable angina is one such entity where you will give medications first, and if the patient is not responding to medication, only then you go for PCI or CABG. So let's get started in this. There are four important pillars in treatment of chronic stable angina. So first is, as the name says, it's angina, right? The first important thing that you will do is prevent anginal attacks. So basically, how do you prevent angina? What is the mechanism of angina? So there is angina when there is blood supply, when there is mismatch between blood supply and oxygen demand, right? So whenever there is mismatch between blood supply and oxygen demand, the patient will have angina. So if there is any medication that is preventing angina, that should increase blood supply or reduce myocardial oxygen demand. So you have two here. You can use medications to do this, or you can advise the patient on how to go on with an activity. Like in previous we learned, right, with the help of treadmill test, we can actually calculate metabolic equivalence of the patient. Depending on meds, how many meds patient can do, perform, or patient require, we can advise the patient for activities. Then second is, you prevented angina. Second, see, even a chronic stable angina is formed by a blockade. There is a blockade, but the blockade is stable here. You want to prevent the increase in size of the clot or progression of new clots. So second is drug therapy for secondary prevention of CVD. Here you prevent progression of clot or blockade or formation of new blocks. Formation of new blocks. Third is, there are certain risk factors like hypertension, increased LDL cholesterol, smoking. You will control all the risk factors and aggravating factors. The last one is, you gave medications to prevent angina, you gave medications for secondary prevention, even then patient has angina. What second line medications will give? That is the fourth aspect. So drug therapy if there is no response to beta blockers or calcium channel blockers. These are the four important aspects in management of chronic stable angina. If there is no response with these, then you will go for what? CABG or percutaneous coronary intervention. Is this clear? Now let's get started with the first one, drug therapy to prevent anginal attacks. There are three important medications here. One is nitrate, second is beta blocker, third is calcium channel blocker. So as I told, they will either do what? They will either increase blood supply to heart or they will reduce myocardial oxygen demand. Okay, now let's get started with nitrates. What do nitrates do? Nitrates actually activate guanylyl cyclase. This causes what? This increases CGMP levels. Now, many of us know that these are blood vessel dilators, but if I ask some students what is the mechanism, they say they increase coronary blood flow. This is not the mechanism of action of nitrates. So what they do is they preferentially dilate veins than arteries. So there is venodilation. Now what happens when there is venodilation? The blood, instead of entering into heart, gets accumulated in veins. So there is reduced preload. Now, when the preload is reduced, your Frank-Starling law comes here. Therefore, there is decreased contractility. Reduced contractility of heart, which in turn reduces myocardial oxygen demand. Is this clear? This should be very, very clear. Nitrates act by reducing myocardial oxygen demand and not by coronary vasodilation. This is the main mechanism of action. Now, what is the use? So, these are just like short-acting bronchodilators in asthma. So, if you will give during episodes of angina, or I told you, with the help of treadmill test, you can actually identify what are the activities that might trigger angina. So during episodes of angina, you give this, or 5 minutes before activity that might trigger angina. Which one is used? Sublingual nitroglycerin is used in the, you will ask the patient to keep that tablet under the tongue. So the dose is 0.4 to 0.6 mg. You can give maximum of 3 doses. Separated by 5 minutes. Imagine the patient is having anginal attack. What is the features of angina? They'll say it's smothering or squeezing type of pain, right? It can radiate to shoulders, it can radiate to arm, or it can radiate to jaw, or it can radiate to abdomen. They'll know what is the type when they are having angina. So whenever they are having angina or they are doing activities that might trigger angina, you should advise the patient that take 0.4 to 0.6 mg of nitroglycerin, keep it underneath your tongue. With one dose, if it's not relieving, wait for 5 minutes, put second dose. If not relieving, wait for 5 minutes and put another dose. So maximum of 3 doses. Adverse effect, because it's a dilator, we know dilator, it causes flushing and headache. Flushing. Do you remember what was other video where we discussed about nitrates and how we reducing preload? That was in HOCM. Do you remember? So in HOCM, what happens? The murmur intensity increases with nitrates, right? What happens? Nitrates reduce preload. When preload is reduced, what happens? Ventricular filling is reduced. When the volume of ventricle reduces. So if this is the left ventricle, if this is the left ventricular outflow tract, the volume of ventricle reduces. So this mitral valve, if you consider this as the mitral valve, it comes close to alveoli and it increases obstruction. Therefore, nitrates are contraindicated in patients with HOCM because they increase the obstruction in HOCM. This is clear. We'll move to next. These are beta blockers. Before going to beta blockers, let's just quickly brush up autonomic nervous system. How many types of beta receptors are there? Mainly 3 types: beta 1, beta 2 and beta 3. So beta 1 is mainly present in heart. So if you stimulate beta 1, what happens? It increases heart rate, it increases heart contractility, and it also increases conduction of heart. Beta 2 is present in coronary arteries. This is not specific to coronary arteries. It is present in many smooth muscles like bronchial smooth muscles, renal, intestine. So in blood vessel coronary, they mainly cause vasodilation. Okay, in lungs they cause bronchodilation. Remember these two important functions of beta 2 receptors. Beta 3 is mainly present in adipocytes and they increase lipolysis. Okay, now if you block beta, what happens? That is the mechanism of beta blocks. The reverse happens, right? So when beta, there is blockade of beta receptors, there is reduced heart rate, there is reduced contractility, and also there is reduced blood pressure, which in turn, so all these things, what they do, decrease myocardial oxygen demand. Myocardial oxygen demand. That is how they reduce angina. Now, increase in heart rate, increase in blood pressure, this happens mainly when a patient is exercising. Therefore, these are mainly effective during exercise than rest. One more important thing about beta blockers is it improves survival and it reduces reinfarction rate. This is very, very important, and this is the reason why we choose beta blockers over calcium channel blockers. So if you compare between beta blockers and calcium channel blockers, you always prefer beta blockers. Only when there is certain contraindication, you shift the patient to calcium channel blockers. Okay, the main use is this. So they improve survival rates and they reduce the risk of reinfarction. Improve survival rates and reduce reinfarction. I told you, right, these are preferred only when these are not we are not able to use them. You actually shift to calcium channel blockers. Now what are the contraindications or adverse effects? So you see this and then tell me the contraindications or adverse effect. The beta blockers reduce heart rate, they reduce contractility, and they reduce conduction, right? The first 4 to 5 side effects or contraindications are related to this. So you don't use beta blockers if the patient has hypotension, or if the patient has left ventricular failure. Left ventricular failure. Then low cardiac output. Then reduces conduction. So if there is any second to third degree heart block. Second to third degree heart block. If there is prolonged PR interval. Prolonged PR interval, which is more than 0.24 seconds. Then one more was it can cause bronchospasm. Beta 2 receptors were causing bronchodilation. If you block beta 2 receptors, it can cause bronchospasm. If the patient has asthma or bronchospasm. And if the patient has any reactive airway diseases. Reactive airway diseases. In these conditions, you won't be able to use beta blockers. Okay. Now, one thing I told, one major important side effect is bronchospasm, right? Because these beta blockers are also acting on beta 2 receptors, you won't be able to use them properly. Like you won't be able to use them comfortably in patients with bronchospasm or bronchial asthma. To prevent the extra cardiac side effects, we have cardioselective beta blockers. So cardioselective beta blockers mainly act on, like they act only on beta 1 receptors. They act only on heart, not extra cardiac tissues. So these are the cardioselective beta blockers. Atenolol, you can remember it as AA, BB, and EM. So atenolol, acebutolol, bisoprolol, betoxolol, esmolol, and metoprolol. This is about beta blockers. Now, third is calcium channel blockers. Now, how do this act? They have mixed action. They cause coronary vasodilation. They increase blood supply. At the same time, they also reduce contractility. They also reduce arterial blood pressure, and they reduce myocardial oxygen demand. So, coronary artery dilation, then they reduce contractility, they reduce arterial pressure. When do you use calcium channel blockers? So first you use it when there is no adequate response to beta blockers plus nitrates. Okay. Then if there is contraindication for the use of beta blockers, what was one of the any asthma, bronchospastic diseases you were not able to use? In that case, you can either shift to cardioselective beta blockers. Like if the disease is mild, you can shift to cardioselective beta blockers, or you can shift to calcium channel blockers. Then coronary artery disease plus asthma. Then coronary artery disease plus peripheral vascular disease. Prinzmetal angina. Nicardipine, nifedipine, felodipine, these are potent vasodilators you can use in angina with hypertension. These are the main uses of calcium channel blockers. Examples there are many calcium channel blockers. I have only quoted practically useful ones. Amlodipine, felodipine, nicardipine, and nifedipine. Verapamil diltiazem. So these are safe, but verapamil and diltiazem should not be combined with beta blockers, because verapamil diltiazem also reduce heart rate. Beta blockers are also reducing heart rate. If you combine both of them, the heart rate might be drastically reduced. Okay. Can you combine amlodipine with beta blockers? Yes, because they have complementary action. So amlodipine is calcium channel blocker. It is reducing blood pressure. It is improving coronary artery blood flow. On the other hand, beta blocker is reducing myocardial oxygen demand by reducing heart rate, reducing contractility, and reducing arterial pressure. So we are done with we have medications that are used in the prevention of angina attack. First it was nitrates, then beta blockers, then calcium channel blockers, then activity advice. So first and foremost thing, you will always ask the patient to reduce the speed of activity. Reducing the speed of activity will actually reduce myocardial oxygen demand. Then avoid strenuous activity in the morning and post-meal. Post-meal, what happens? Blood circulation is mainly diverted to intestines for absorption of all the nutrients. In the morning, coronary arteries are more prone for spasm. So you will advise the patient not to do heavy activities post-meal and in the morning. Then advise activity according to metabolic equivalence. You prevented angina. Now you should also prevent expansion of the clot or formation of new clot. So what all will you use? There are 4 main medications: antiplatelet agents, AC inhibitors, statins, and antihypertensives. So if you don't remember anything, you should remember this one. Aspirin. Aspirin is something you should never forget in the treatment in patients with IHD. Okay. How does aspirin act? It is irreversible COX inhibitor. cyclooxygenase enzyme inhibitor. We'll read about antiplatelets and anticoagulants in detail, like what is the pathway of antiplatelet, like how platelet aggregation takes place, how what is the coagulation pathway, and how these medications actually act on those pathways. Everything in detail we'll learn when we are studying about management of NSTEMI and STEMI. So for now, just remember aspirin is irreversible COX inhibitor and it inhibits platelet aggregation. So daily dose is 75 mg per day. Then apart from that, you can also use P2Y12 inhibitors, which is clopidogrel, ticagrelor, and prasugrel. Major adverse effect of all these is they increase the risk of bleeding. Second is AC inhibitors. Okay, one very interesting thing about this, you know that AC inhibitors are used in the management of hypertension, but one thing that you should remember here is it is especially useful in a patient with IHD with diabetes mellitus. Coronary artery disease plus diabetes mellitus, and if the patient has coronary artery disease plus reduced left ventricular ejection fraction. Why? Can you say why? Because it prevents cardiac remodeling, right? Reduced left ventricular ejection fraction. Third, statins. Statins are also very, very important. They reduce LDL cholesterol mainly, and to some extent they also increase HDL cholesterol. Okay, the fourth one is antihypertensive. If the patient is hypertensive, you should always control the blood pressure. Third, you will control risk factors and aggravating factors. There are certain risk factors. When we were reading about pathogenesis of chronic stable angina, we understood that smoking, elderly age, LDL cholesterol, hypertension, they were all doing what? They were damaging blood vessels, right? So to prevent further damage to blood vessels, we should keep all these things under control. Obesity, cigarette smoking, should ask the patient to reduce weight, quit smoking, and to keep cholesterol levels, blood pressure, and diabetes under control. There are certain factors that can aggravate angina: left ventricular hypertrophy, HOCM, hyperthyroidism, anemia, and aortic valve disease. So, all these factors, all the risk factors and aggravating factors should be kept under control, properly treated. Coming to the fourth one, you tried nitrates, you tried beta blockers, you tried calcium channel blockers, you also added antiplatelet medications, you have advised patient regarding exercise, you have controlled all the risk factors and aggravating factors, and still patient has angina. What are the other options that you have? So you can try second line medications. First, you can consider monotherapy with Ranolazine, Nicorandil, Ivabradine, or long-acting nitrates. First, let's start with, this is monotherapy. Let's start with Ranolazine. So this inhibits sodium current, thereby inhibiting calcium current. I'll show you. Imagine this is cardiac cell. This is nucleus. Okay. Now here there is sodium channel. From this, sodium is entering into the cell. Okay. It enters and then it gets accumulated inside the cell. Now what is happening? This sodium is getting exchanged with calcium. Now sodium is going out and in turn the cell is getting calcium. Now intracellular calcium increases, which in turn increases contractility of heart. So what does Ranolazine do? It blocks this sodium channel. Now, what happens when there is there is inhibition of sodium current. There is no exchange of calcium with sodium. So when intracellular sodium reduces, intracellular calcium is also reducing, and therefore there is reduced contractility leading to reduced myocardial oxygen demand. Correct? So this reduces contractility of heart. Apart from that, it also reduces fatty acid oxidation. This is your NEET question as well. Which anti-anginal medication actually reduces fatty acid oxidation? The answer is ranolazine, and increases glucose oxidation. This is about ranolazine. Then Nicorandil. Nicorandil is ATP dependent potassium channel opener. Okay. Now what happens? Causes vasodilation. This is about Nicorandil. Third is Ivabradine. Remember the name. There is Bradin. So what does it do? It is funny current inhibitor. Funny current inhibitor. It reduces SA node activity. Like it reduces heart rate. That is why there is Brady in the name. Thereby it reduces oxygen requirement. Apart from that, to abort anginal attacks, we are using nitroglycerin. Here we are using long-acting nitrates. So you can use isosorbate mononitrate or isosorbate dinitrate. Mechanism of action is same. Only difference is the duration of action. Okay. Isosorbate mononitrate, you can give SR preparation, sustained release, 30 to 240 mg per oral per day. 30 to 240. So if you see, right, if there is any angina patient and if you see their case sheets, you can find one very common brand, Imdur 30 once a day. Then you can also give isosorbate dinitrate 10 to 40 mg per orally 2 to 3 times a day. If there is no response to all these four aspects, then you will send the patient for PCI or CABG. We will learn about PCI, CABG, their indications very depth in further videos. Okay, this is about treatment of chronic stable angina. I hope this is very clear. I'll just quickly recap what all we learned till now. Okay. So there are four major aspects. One is you control angina. You will reduce the episodes of angina. You will reduce the progression of clot or formation of new clot. Then you will control the risk factors and aggravating factors. If there is no control with first line, you will add second line medications. In preventing anginal attacks, there are three important medications: nitrates, especially nitroglycerin, nitrates, beta blockers, and calcium channel blockers. So nitrates, beta blockers, they mainly act by reducing myocardial oxygen demand, whereas calcium channel blockers increase blood supply, also reduce myocardial oxygen demand. Okay. So important thing about beta blockers is they improve the survival rates and they reduce reinfarction rates. So to reduce the extra cardiac adverse effects, you can use cardioselective beta blockers, which is AABBEM. Okay. Then wherever you cannot use beta blockers, or if the patient has coronary artery disease with asthma or prinzmetal angina, or coronary artery disease with peripheral vascular disease, or coronary artery disease with hypertension, the preferable one is calcium channel blocker. Then you will advise patient for activity, slow down the pace, avoid strenuous activity post meal and in the morning, and advise activity according to metabolic equivalence. For the prevention, if you don't remember anything, remember at least aspirin. Aspirin is used, then you can use P2Y12 inhibitors, antihypertensives, statins, AC inhibitors. AC inhibitor, even though that is mainly used in hypertension or heart failure, here the benefit has been shown in patient with coronary artery disease with diabetes mellitus. Okay. Then control of risk factors and aggravating factors. So if there is no response to first line medication, you can add second line medication, which are ranolazine. Ranolazine inhibits sodium current, which in turn inhibits calcium current, reduces contractility, it reduces fatty acid oxidation, and increases glucose oxidation. Nicorandil, potassium channel opener, causes vasodilation. Ivabradine, Brady, remember the name Brady in Ivabradine, so it inhibits SA node, okay, reduces heart rate, reduces myocardial oxygen demand. Long acting nitrates, azosipam mononitrate, dinitrate. Mononitrate, remember mononitrate, 30 to 240 mg SR, Imdur 30. No response, PCI or CAG. So that's it from my side.